Hello everyone, welcome to HIM 216. And in this lecture we're going to be covering Chapter 4 in your textbook. Chapter 4 begins on page 73. And basically we are going to be covering the basic steps of coding in this chapter and in this lecture. If you'll look on page 73, it begins by telling you what those basic steps of coding are. You start off by reviewing the health record, and we review all the documentation in the health record. While we're looking at that chart, we start identifying the different diagnoses and the procedures that we should be coding. We're also going to identify our principal diagnosis and the principal procedure if we have a procedure. Once we know what we're going to code, we're going to find those main terms in the alphabetical index. We're going to then look at the subterms in the index to see if there's a more specific subterm. If there are any cross-reference instructions such as see also, we're going to follow those. Then we are going to verify that code in the tabular. We're going to look at any instructional notes in the tabular, and then we assign the code to the highest level of specificity, meaning that if there is a subcategory, we assign the code from the subcategory and not to the category. And you'll know this with the integrated codebook because the codes you can assign are blue. The codes you cannot assign are red. And then we assign all diagnosis codes and procedure codes, and we sequence them, and we do it all in accordance with the coding guidelines. Another term for the coding guidelines to me are the rules. You can't really play a game or participate in anything if you don't know what the rules are and you don't know how to play that. Well, in coding, the coding guidelines and Coding Clinic are the rules, and you have to follow the rules. And CMS doesn't care if you really understood it or not. They require that you follow the rules. And so that's why we have such a focus on covering those coding guidelines and making sure that you understand the coding guidelines, because those are the rules you have to follow when you're coding. We want very accurate and complete codes. We also want to make sure that we are providing the legal maximum reimbursement that we can for our facilities without committing fraud or abuse. Now, when we start looking at a chart, and I'm on the bottom of page 73, the first thing we're looking for is we're looking for the principal diagnosis. And your book reminds you of what that definition, it's the condition determined to have occasioned the admission. And then we want to look for other reportable diagnoses and procedures. And this is where you may need to go back to Chapter 2 and look at the definitions of what is a reportable diagnosis. It's not just anything that we see documented. There are guidelines for reportable diagnoses, and then of course for reportable procedures. The first document that you really want to take a look at is the discharge summary. If it's available, it may or may not be available. Typically, the physician will summarize what he did for that patient in that discharge summary. Sometimes they repeat the whole history and physical. But they typically go over the reason that the patient came in, what their findings were, how they treated them, how they responded to treatment, what their discharge diagnosis is, if there were any procedures that they performed, and then there are certain things that are consistently should be in there. Their discharge instructions, when are they supposed to follow up, what medications are they being sent home, what is their activity level, and those kinds of things that you should find in that discharge summary. Sometimes you don't have one. Sometimes coders do not have a discharge summary, but they feel comfortable enough with the documentation in the medical record that they go ahead and code that chart. It's not uncommon for facilities to route charts back to coders once a discharge summary is available. And of course, if the coder feels that she needs the discharge summary before she can code that record, it is certainly her option to say, no, I can't code this without a discharge summary. And when we talk in terms of a discharge summary, we are talking in terms of a patient who is in inpatient status. When a patient comes to a hospital, they are either in inpatient status or they are in outpatient status. There are different documentation requirements for inpatients versus outpatients. The coding guidelines are different for inpatient versus outpatient. In the first 25 chapters of this book, we are talking about an inpatient status, and that's a patient who has been admitted to inpatient status. Some examples of outpatient status are patients that come in for outpatient surgery and then go home, a patient that comes into the ER and then goes home, a patient who comes in to maybe just have lab work or to have x-rays or to receive physical therapy. Those are outpatient statuses. The patients do not stay and spend the night in the hospital. What is confusing is that there is a status called observation. When patients are in observation, they actually will be on the floor in a bed and they may spend the night in the hospital, but they are not in inpatient status. Observation is an outpatient status, and it's a huge area and a focus for Medicare right now, because sometimes patients are inappropriately placed in an observation status when they should be in an inpatient status, and vice versa. So there's a lot of discussion as to how to move forward with these types of cases. But an observation patient is an outpatient. Very important to know. And it has a difference. For the patients, usually their financial liability is different when they're an inpatient versus being an outpatient. So status is a very important thing. Now, if there's not a discharge summary, usually the next step for the coder is to look at the ER record. Now, just to back up a bit, on the top of page 74, it talks about the reasons that the discharge summary isn't the only document that you're going to want to look at. One of the primary reasons is that most physicians don't understand coding guidelines, and they're not required to. That's our job, to interpret that record and to assign the principal diagnosis code and the principal procedure codes. Sometimes physicians will document things in the discharge summary that we just don't code. Like the patient had pneumonia 4 years ago. That is something we would not really usually code. They may say the patient has a history of hypertension when in fact they do have hypertension. They've had it for a number of years. That may be why the physician says they have a history of it, because it wasn't newly diagnosed on this admission, but it's not really a history of. They have it. They're being treated for it, and so we code it that way. When we look at the ER document, we're looking at the chief complaint. That usually gives us a good idea of why the patient came in. Sometimes it's a sign or a symptom, and we do assign a code for the admitting diagnosis, and it typically needs to be why they came into the ER, or the documentation by the ER physician of the admitting diagnosis. And you'll see different types of things documented, and your book goes over those. I'm not going to go over those in this lecture. You can read those in your book on page 74. Now, we've been looking up codes. This chapter actually talks about, again, goes over the process for looking up a code. It does tell you that the first most important concept that a coder has to know is the definition of the principal diagnosis and the principal procedure. But the second most important concept is that you must verify your codes in the tabular after you look them up in the index. You're going to hear me say that over and over. You're going to see me do it as I demonstrate finding codes, and still some of you are not going to do it and you're going to get codes wrong. So a point in time will come that if I can tell that you did not verify the code in the tabular, that you assigned it from the index, I'm not going to give you any credit for it. So initially I'll remind you that you assigned the code from the index and didn't verify it in the tabular, but a point in time will come that I won't give you even partial credit when you do that. When we are coding in the procedural coding system, we actually use the index to lead us to the correct table, and we actually can code directly from the table. And if you play around in these PCS codes, this is what a table looks like, and we'll actually do this extensively in the weeks that we spend on Chapter 6. Now, if we go to exercise 4.1, basically we're looking at different types of pneumonia. And you're told to assign the codes for these diagnoses. And the first one is aspiration pneumonia. And we can see right away that aspiration is not a non-essential modifier. So we're going to look it up and we can see that that code is J69.0. If we know what they aspirated, then we can certainly assign a more specific code than J69.0. If it was food, we would assign the code J69.0. The next one is Escherichia coli pneumonia. Now, your book says Klebsiella pneumonia. So if I can look up Klebsiella and find the code for Klebsiella pneumonia, J15.0. If I look up due to, I will not find. This is an example of where there is not a specific subterm for due to. I just have to look up the Klebsiella pneumoniae to get the J15.0. Then we have a Mycoplasma pneumonia, and our code J15.7. And then we have varicella, so pneumonia, varicella B01.2. And then we have viral pneumonia, so pneumonia, viral, and that default code is J12.9. You can see that we have broncho, interstitial, lobar as non-essential modifiers, but then we have essential modifiers that have more specific codes. Let's look at the third example on page 75. Patient has a diagnosis of hiatal hernia. The main term is hernia. The subterm is hiatal. Main terms are usually nouns and or diseases. The main terms are listed down in this example. And if you try to look at, if you look at gastric, see, it tells you to see condition. You can look it up, you just won't find anything. But if I go to upset, then I can find gastric, K30. Chronic mastoiditis. Now, chronic and acute are terms you can never look up. Don't even try, because there's just nothing there. But here's mastoiditis, and I want you to notice that we have a subterm for acute and subacute. Then we have our code for chronic, And once we go to H70.1, you see this has a little dash after it. It's a red code here, and so we have to come over here, and this is an example of laterality. And we would be using H70.10 because we don't know which ear it is. But if it were the right ear or the left ear or bilateral, we have codes for laterality in ICD-10. So you have to be careful. And I'm often going back and forth from the example to the code book. Now, what was that? Was it right? Was it left? So specificity can sometimes be a challenge. And look, we have etiology manifestations right here. Mastoiditis in infectious diseases, parasitic diseases. So these are etiology manifestation codes, so we know we have to list both codes and that we do not use the brackets or the underlining or the italics. And then herpes simplex. If we look up simplex, it says C condition. So if I look up herpes and then simplex, I will find this code. And of course, if I have more information and not just the diagnosis of herpes simplex, but if I have something more specific, there is a more specific code. In the next example, the patient has a diagnosis of appendicitis, and the op report says that the procedure was a laparoscopic appendectomy. And we're not going to spend a lot of time on this. When we go to appendectomy, you can see that it sends us to a table. This table that we choose depends on whether or not it was an excision or a resection. These are root operations. They have very specific definitions, and you have to know whether or not the procedure that was performed meets the definition of excision or resection. I know that it's going to be a resection. Nobody takes out part of an appendix. And so that takes me to the table, and when I get to the table, then I actually choose the approach, which also is defined, and we'll study that in detail when we get to the procedural coding system. On page 77, it talks about C and also different ways that sometimes you can look up codes, and we have gone over that. Continue, read that in your textbook. Look up these particular examples. Don't spend time on the PCS tables because we're going to spend about 3 or 4 weeks studying the procedural coding system. On page 79, it talks about looking up terms in the index to procedures, and we're not going to go over that. And then exercise 4 to underline all main terms used to locate a code in the index. And I'm going to provide you with this information for the odd numbered questions, and you can actually look these up. For esophageal reflux, we'd look up reflux. Esophageal is a body part. We won't find a code there. For number 3, iatrogenic thyroiditis. The disease is thyroiditis. The type is iatrogenic, so we would look up thyroiditis. For number 5, we would look up disease, and then artery, and then coronary. For number 7, we would look up arthritis and then rheumatoid. Now, sometimes you can look up other terms. For instance, let me see if... See, for rheumatoid, it says see also condition, but then there's arthritis and it says see also arthritis rheumatoid. That's what you need to do. There's really not a lot here. You'll find the most specific information by going to rheumatoid arthritis, and it has all the different kinds of rheumatoid arthritis with these different disease processes, juvenile, seronegative, seropositive. So this is much more specific coding than just going to rheumatoid and looking at those few codes they have under arthritis. We have on page 80, it talks about the tabular. This is the alphanumeric listing of diseases. I want to show you something with the tabular that actually my students taught me. I would never think to try to do a text search in the tabular because it's alphanumeric, and I am going to the index and finding my codes or putting the codes here in code search. But if you do this text search, and you do have to fully spell, and spell correctly. So for instance, if I put in the term hemorrhoid, these are all the different codes in the tabular that include the term hemorrhoid. Now, should you code from this? Absolutely not. You should consistently code from the index. When this might be helpful is, let me show you something else. Sometimes there are just terms that are difficult to find. So for instance, let's say that my type 2 diabetic patient gets insulin. So that is long-term use of a drug. And I just can't find that. I can't find it in the index to get me to the tabular. So if I just type in index in the tabular, I come over here and look, Z79, long-term current drug therapy. So sometimes it can help you look at the terminology to then go and find the code. So for instance, if I come to the index and put in long-term, and you have to put in those dashes too. There is my code, long-term use of insulin, Z94.4. So sometimes it can help you that way. It's not something that I really ever do, but the students did, and they said that it helped them. I want to point out to you that at the end of every chapter there is a chapter glossary. You should read through these terms, be very familiar with these terms. These are terms that were used in the chapter, and you need to be familiar with that terminology. Now this is going to include the lecture for chapter 4, and your question for this chapter is I want you to look at exercise 4.2, and actually I want you for number 1 and number 3, I want you to actually give me the code. So I want you to look it up in the index and then tell me what the code is for esophageal reflux and what is the code for iatrogenic thyroiditis. And that will conclude this one and only lecture for Chapter 4.